Good evening, everyone. You're more than welcome. Sinead McNamara is my name. I'm the organizer of the inaugural National Menopause Summit, supported by Marks and Spencer. Our wonderful partners on the event are Marks and Spencer. And this is the second in a 4-part Monday evening at 7 p.m. Insta Live on menopause supports with Marks and Spencer. Last Monday, I had the great pleasure of chatting with Dr. Kiva Hartley, and that's still on the We Are Best in Fest, and I'm sure it's on the Marks and Spencer Insta as well. So I was chatting with Dr. Kiva Hartley, who is the lead medical officer at the Rotunda Menopause Clinic. This evening, I'm speaking obviously to the fabulous Dr. Deirdre Lundy, and Deirdre is the lead medical officer at the Complex Menopause Clinic at the National Maternity Hospital, Holles Street. And just to get a little shout out for our next two Insta Lives. Next Monday, I will be speaking to Loretta Dignam, and Loretta is the founder and CEO of the Menopause Hub. And then the final Monday, which is the Monday before the event, can't actually believe it's less than 3 weeks away. Our final Menopause Supports with Marks and Spencer will be a chat with Sally Ann Brady, who is the founder of the Irish Menopause, she has an amazing support group on Insta and Facebook with over 49,000 followers at this point. So delighted to have the opportunity to introduce everybody to our speakers, or some of our speakers that we're featuring at the event, and have a chat and get, I suppose, the word out there more broadly, isn't it, Deirdre? I mean, you know, everybody has access to Insta. Not everyone can come to an event. So
exactly.
We're very, very keen to get as much information out there as we possibly can. So I'll kick off, Deirdre, by saying, obviously, your role as lead medical officer at the Complex Menopause Clinic at the National Maternity Hospital, Holles Street. Can you explain to us all exactly what complex menopause looks like?
Sure. So when the National Women and Infants Health Program, NWIP, put aside money for menopause care for the 6 different clinics around Ireland, we thought, well, that's an amazing step in the right direction. But we quickly realized that if we accepted every patient in Ireland who ever experienced a hot flush, we wouldn't be able to cope with the demand. Moreover, most of the needs of people going through menopause theoretically should be able to be managed in general practice. Yeah, we do a lot of work with GP colleagues. Many of us are GPs, so we feel their pain and we try to support them as best they can so that patients with straightforward menopausal needs and medical histories can go to an educated, compassionate GP and get good care. Yeah. But a lot of the guidelines will say, if a patient suffers from this, that, or the other disease, or has had this experience in the past, their menopausal options should really be managed by somebody with specialty training. Okay. So my colleague Nicola Cochran in Holles Street, Quiva, who you already met out of the Rotunda. Yeah. We're all members of the British Menopause Society specialty team. We have a further accreditation as both specialists and trainers of other specialists in menopause care. So we have more than the average GP training, which is great. But for us, we're focusing most of our work, and I think Cleve is doing the same thing, on people whose needs are greater than what GP usually is empowered to provide. So the majority of our ladies will have had some other form of hormone-sensitive cancer, usually breast cancer, because that's the commonest cancer in women after skin cancer. Other forms of cancer, which are known to have an estrogen link, like ovarian, womb lining cancer as well. A good few of our ladies will have had a personal experience of a blood clot, like when they were on the pill or if they were pregnant. Right. And then typically people would run a mile from hormones. When it comes to the menopause needs of those ladies, we don't run. We actually consider those easy patients.
Okay, well, can I just jump in there, Deirdre, because that's an interesting one, because from a layperson's perspective, and I know I'm 54, I'm in menopause, but in terms of our education levels around everything to do with menopause, personally speaking, I'm early in the game here. Do you know what I mean? Because I would have thought in the past, or I suppose I would have gleaned this information somehow, that if you had a pre-existing condition, that, you know, HRT was something you couldn't actually consider even getting involved.
Yeah.
Has that changed? And I know it's on a patient by patient basis.
Yeah,
but has that changed?
We take everybody as an individual, but absolutely, if you've had a hormone-sensitive cancer diagnosis in the past, and breast, ovary, womb lining are probably the three biggest ones.
Yeah.
You're much better off trying to address your menopausal needs without systemic HRT, without putting hormones into your blood. You can generally use the hormones that go through the vagina, but you really don't want to be overloading the system with blood, because we don't know for sure that it won't do you harm. We don't know for sure that your cancer won't come back or pop up in a distant part of your body as a result of malignant spread. So we try as best we can to try to modify the symptoms and improve your quality of life through other options. And it doesn't always be drugs. A lot of times it's lifestyle therapies and, you know, non-prescribable interventions, like all sorts of stuff. But there are some cases where the block capital advice would be avoid HRT, and one of those would be blood clots. But the modern thinking is actually we do know what happens when you use HRT after a person has had a blood clot in the past, especially if you make sure that that form of HRT is not a pill,
right?
A patch, a gel, or a spray, and that it's at a modest dose. And we know for a fact that it does not increase your future risk of blood clots. So that's why I facetiously say those ladies are easy, because I know when I write the prescription, I am doing no harm.
Gotcha.
Whereas I don't know that yet if I write a prescription for estrogen for somebody who's had a breast cancer. Yeah. I mean, that information may eventually be available to us as more and more people you know, are being studied and observed with these modern products and these low doses and these non-oral delivery systems. We've come a long way from the old horse's pee, if you know what I mean.
Yes, indeed. Kiva was talking about the horse's pee last week. But I suppose the technology is evolving all the time, isn't it, Deirdre? So, you know, there's, you know, potentially there are solutions on the horizon that wouldn't be available to us right now.
Most of the information we'll quote to you, you know, a doctor's talking to a patient, is based on that 22-year-old study from the United States, where they looked at those thousands and thousands of ladies on the horse's wee HRT tablets. So we're waiting to amass the data from these last few years. And really, it's only since about 2015 that HRT kind of got legs again. So,
of course.
Talk to me in 2025. By then, we'll have 10 years observed data on things like breast cancer risk and modern HRT, which may change the whole picture. We don't know.
Yes,
we don't know.
Indeed. Absolutely. And here's a question for you, not particularly related to complex menopause, but it's just something you mentioned. And Kiva mentioned the same thing as well. I'm interested to know what the answer to this is. So Kiva, I got the sense from Kiva, she didn't say this, but that, you know, menopause delivery systems through patches and gels are generally better than tablets. Is that the feeling these days? Yeah.
Better is kind of a loaded word, but certainly it's more body identical. So the molecule of estrogen that you can get into your blood if you use something that goes through the skin, whether it be a gel, a patch, or a spray, that's all we have at the moment in Ireland, is the same 17 beta estradiol molecule that your ovary makes during your fertile years. Gotcha. It is what some people call bioidentical or body identical. We don't know for sure, but we expect that the observational data that we're going to see over the couple of years, you know, that we've been doing this stuff, will show that that type of estrogen is more favorable for women's bodies than the old conjugated equine horse's pee tablets.
Right. Okay. Gotcha. Yeah. And in terms of, as you were saying there earlier, the management of complex menopause, and if, for example, I have a couple of the markers or people present to you and really going down a regular HRT road with them is not an option. What
Yeah.
is the likelihood of them having manageable and good outcomes without that?
Well, you know what? It's amazing. Like we always say, oh, each patient should be seen as an individual, and never is it more true than when it comes to people who have those complex needs, and particularly our breast cancer cohort of ladies, because it amazes me how we'll have a full conversation with everybody. We'll take people through all the available options and give them information on what we know works, what might work, what probably won't work.
Yes.
And then we'll see where their inclination lies and ask them to give something a trial. And it is absolutely a total crapshoot as to whether they'll get benefit.
Okay.
Like I call people up, I'll prescribe the same, or I'll recommend the same course of treatment for two ladies with the same type of breast cancer. They're exactly the same age. And one lady will say 3 months later, oh my God, that has completely improved things. You've really helped me. Thank you so much. And the other lady, same damn stuff, will say, well, that was a waste of 3 months. You know, you just,
I know.
It's amazing. It's amazing. I mean,
the individual nature of human bodies, really. It's just, we're not, we're not like the Borg. If anyone is a Star Trek fan out there, we're not like the Borg.
No, you know, it's not an algorithm. Everybody's a person, and they all get a shot at the different stuff. The one thing I will say is, in general, the hard things are the most universally beneficial things. And what I mean by that is moving more, eating better, drinking less alcohol.
The kind of stuff that most of us don't want to hear too much about, Deirdre, to be fair. Let's be honest.
Me included, me as well, you know, as I'm sitting here eating my 5th apple for the day, Jesus Christ, you know. But like, if you are struggling and you need help and someone says to you, oh, just lose some weight and don't drink anymore and stop all that smoking and take up exercise, you want to hurt them. You know, you do.
Yeah. You're like, can you point out more of the bleeding obvious to me, please, and ruin my Monday? That's absolutely fantastic. Yeah.
So we always mention it, but we don't emphasize it, because my feeling is, if somebody could give you something or help you find something that made you feel better, you would then have the energy and the optimism to move more, eat better, smoke less, drink less. But don't be telling me that it's like a carrot stick kind of a thing. Like, I haven't the time for that. Yeah.
No, absolutely. And Deirdre, what is your view on sort of I have to spoiler alert, I know the answer to this question. I know, I can't even pretend I don't. What is your view on, you know, supplements? So if someone decides that they're not going to go on HRT and they think that it's a better option to buy something in the pharmacy, take a tablet, drink something, what is your view on that?
Well, you know me, I'm kind of like a science person before
like me,
everything. And if there is no data, if there is no provable association between one thing and the other, then I'm not going to recommend it. I could say, sure, go ahead, try it. But any studies I've read will say this, that, or the other. I mean, if you have like serious food restrictions and you're not able, or you choose not to enjoy a nice array of foods, then you might need some vitamin supplements.
Of course,
and certainly everybody in Ireland, particularly people who come from hotter places, needs vitamin D, because this is like living in a cave.
I know, it is a little bit, particularly today is showing cave big time for us, for sure.
And we, all of us, women particularly in menopause, need supplemental vitamin D, no question about it. But if somebody's telling you that this broad range of vitamins is going to somehow get rid of significant menopausal symptoms, the facts don't back that up. I'm sorry, they just don't. That's not to say that it might work for that lady or that lady. Just like my other drugs do sometimes work for some ladies, but not for others. But will it have the impact of hormones? Will it protect your heart and your brain? No, absolutely not. So if you're going to use vitamin supplements, and do if you need them and if you feel you want them, that's absolutely fine. Don't be spending money on something with the word menopause on the front. That just galls me. I feel there's an exploitation there. Like, no more than I'll be buying menopause shampoo or menopause face cream, which is on the television all the time at the moment. Just use your common sense and get an affordable multivitamin. And particularly, I do use prescribable vitamin D myself because I'm lazy. I know I won't remember to take a daily supplement. So you can get your GP to prescribe you like a mega dose that you just take once.
That's interesting. I didn't know that because I'm a vitamin D fan as well.
It's a one a month.
Then I run out of it and I forget about it. And then I have a few weeks where I haven't taken it, that kind of way. So that's interesting to know.
I make my whole family, I put them on the kitchen table like Smarties. And I'm like, on the first day of every calendar month during the winter, I make everybody swallow a big red 25,000 international units of vitamin D. I feel my parenting goals are achieved.
Brilliant. Well done. Hats off to you for that, Deirdre. And this is a question that I asked Kiva as well last week when we were kind of discussing a more regular, I hate to use the word regular menopause, everyone, because I know it's all very personal to all of us, but a more typical menopause. And I was saying to Kiva last week, if you sort of haven't, that you're in menopause by virtue of your age and you're probably suffering from the symptoms and you haven't sort of taken that leap to go and see your GP or you obviously you have pre-existing conditions that are going to be a problem. Is there an issue if people come to you, sort of in their mid to late 50s, early 60s? Can you still help them at that point?
Age is never a barrier. There was a little bit of a misinterpretation of some of the data from that WHI study that I think it's gone around the houses, and it really needs to be clarified. And what it's about is we know that estrogen in general is beneficial for the heart. It keeps the blood vessels that supply the heart muscle and our brains clean. And it prevents the deposition of atheroma, which is that gunky plaque stuff that can cause narrowing of the arteries and cause strokes, heart attacks, angina, that kind of stuff. And estrogen tends to slow down the deposition of those plaques. And that cardiac benefit, that benefit to the blood vessels, seems to only work if you get on hormones and stay on them before your 60th birthday or within the first 10 years after your last natural period. So there's there's a window that if a woman comes into me and she's 63, 64, and she hasn't had a period in 15 years and she is suffering, does that mean I can't give her hormones if she wants them and she doesn't have contraindications? Of course not. She can use hormones, but what she probably won't get benefit from is atheroma prevention. That window has closed. But it doesn't mean that the minute you turn 60, you become a ticking time bomb for a heart attack or a stroke. Of course you can use hormones. You just got to be very careful with the products, go in very gently and slowly with the doses, and only address the symptoms, that are really bothering you. Everybody's an individual, like we said, but certainly older people, and this is a huge generalization, wouldn't need quite as much estrogen typically as much younger people. So like I have girls in their late teens, early 20s in my premature menopause service that could be on 125, 150 or more of estrogen patches, whereas I often cut my 50 in half. So I'm only on like maybe 25, 37 and a half. Because I don't need as much as those kids, because I'm an old lady.
No, we're not old, Deirdre. We're just like fine wines. We're mature. We're not old. Mature.
I'm a senior. I get the Woody's 10% on Thursdays.
Brilliant.
And they don't even ask for proof of age.
Well, I would complain. I would absolutely make a formal complaint to Woody's on that one. But I suppose the same rules apply, broadly speaking, if you can do it, whether you are going through a typical menopause or whether you're going through a complex menopause. Get thee to your GP or whomever or your menopause clinic as quickly as possible. Why suffer, ladies? Why wait? Why spend a few years or any period of time, misery or suffering symptoms? Get there and get yourself sorted. Isn't that it?
I have to say, because most of my accreditation and educational work is received from the UK. even though I'm
Yes.
giving out information in Ireland. So I'm a member of the questions and answer groups for British menopause, doctors who deal with menopause. And I look at the caliber of the questions from the members and I think, are you a real doctor? No, I shouldn't say that, but whereas me and Brian, my buddy Brian, he's a GP down in Nina, he's going to be at the event, he runs a service, and I chime in, where a GP can go on their phone actually, and ask questions about menopausal care and hormones and stuff like that. And the caliber of the Irish people, the Irish prescribers, doctors and nurses that are on that forum, it's just so high, and their devotion to their patients is so
great
good.
To hear.
Oh my God.
Yeah, that is great to hear.
I know that may not be your individual experience, depending on where you live, who your local GP is, but my God, the expertise is out there. We have almost 1,000 people. We have almost 1,000 doctors in Ireland that are actually on that.
That's incredible. That is incredible. And I suppose, it's wonderful, as we all know, to have menopause specific clinics.
Yeah.
But I know that Brian is very experienced in female health, and he's a fantastic advocate. He's a lovely guy, and we're delighted he'll be as Deirdre said, he will be at a panel in the afternoon session at the National Menopause Summit, supported by M&S, which is the journey through menopause. So we're delighted to have Brian. He's our only guy. We tried to get guys. We did try. He's our only guy, but Brian will be talking about, Deirdre, as well, the importance of your GP in this journey. You shouldn't have to go to a particular menopause clinic. You should be able to be looked after by your GP.
Most people, it's not that challenging. Yeah. And the rules are there are rules and guidelines, and they're pretty straightforward, I think. But you got to remember, and I'm always saying this because I want to support the side, like general practice is probably under more pressure nowadays, post-COVID, with the lack of recruitment and positions elsewhere. Like all my friends are retiring or looking at retirement. And it's really hard sometimes for a GP to find the time to actually convey the information they'd like to be able to convey to you, even when they do want to talk to you about menopause. So doing as much of your own pre-reading and getting a sense, and that reading has to be done on reputable, accredited websites and books, not,
of course.
Yeah, exactly. That really helps. That'll help.
Not fairyland stuff. And Kiva was saying last week, just for everybody who may not have joined us last week, that there's a number of different platforms online. I think she said the Australian Menopause Society have an amazing document that anybody can download. And you can literally, it lists all of the symptoms, and you can go through it before you even go to your GP, and you can tick off what it is that's ailing you. And then at least when you get into your GP, you can use your time as wisely as possible, not wandering around the houses, trying to get to the bottom of the problem. Exactly what it is that you want to discuss with your GP. And that's really, really helpful. We'll be covering that as well. I know yourself and Kiva will be talking about that at the event as well, Deirdre, because I think that's an amazing facility that not everyone is aware of. Do you know what I mean?
No, I think that really helps, because you got to remember, when we first started, we're over a year now officially accepting referrals from GPs in the Hollis Street Clinic. Quiva got going, but she was a little bit later to the party. But like, you can't just go to your GP and say, oh, send me to Quiva or send me to Deirdre. You know what I mean? We only deal with very, very specific people, and the GPs they know who will take and who we won't take. And just wanting to talk to us isn't sufficient. You know what I mean? You do have to have had some kind of an experience where, you have special need. But that's okay, because there's so much can be done in general practice if you know what you're doing. And then if you're an educated consumer going into a GP, who maybe even is a member of our Telegram prescribers support group, when you put all those moving parts together, you're going to get a good experience, I hope.
Yeah, no, that's fantastic. And in terms of, I hate to discuss waiting times and all of that kind of stuff, but let's tackle it. Are you working through a massive backlog in the National Maternity Hospital Complex Menopause Clinic? Yeah.
Sadly, and that's partly my own fault because I didn't want to wait for all the services to get up and running. I wanted to get going immediately.
Yeah.
So it meant that when we first started to take referrals, we didn't have any catchment areas because we couldn't do that. There was nobody else working in the area. So we felt, yeah. And we would look at the letters coming in and we would see what we felt was the most great and urgent need. And we would give those patients a priority. As the Rotunda service and more recently the Coombe services have started to evolve, that we've got Kathy down in Limerick and Brenda in Cork and Marina in Galway have all started to accept referral letters now, I believe. Where now I can say, hang on a second. If you're in Cork, do not be sending your patients to me in Hollister. So that'll help. Yeah, that'll help. And then obviously having to keep to the very stringent referral criteria. So
of course,
hormone sensitive cancer, blood clots, very serious liver disease, people living with HIV. I think we need to give those ladies a particular kind of a leg up because their need can sometimes be great. And also it's a little bit unclear as to what the medicines will do to each other, you know, the retrovirals and the HRT and stuff. But really beyond that, it's general practice.
Okay, brilliant. And I'm just taking a little look here at my cheating and looking at the questions I had written out just to see if there's anything that I wanted to ask you. No, I think we've covered everything I wanted to ask you, Deirdre, but is there anything in particular? Oh, yes. I know there was one thing we want to talk about before we go, and we'll finish up soon because we're nearly half an hour in. When you and I were having a chat last week in terms of laying out what we discussed this evening, you were talking about people who chose to travel to the UK to specialist clinics over in the UK. And let's hear your thoughts on that.
That's an important thing to pull out here because it happens a lot. So if you go to an Irish GP and you get a 20-minute, 15-minute consultation, you pay Irish GP fees. If you go to a private menopause clinic, whether that be in Ireland or in the UK, online or in person, you're going to pay a heck of a lot more money. In some of those private clinics, not all, they make lots of recommendations for
this in the
tests.
UK now. This is the UK clinic you're talking about.
And sometimes in Ireland. Ireland, I've heard tell, I don't have proof, that, you know, people will recommend you should get a saliva test or a blood test, and you should try this and you should try that. And that, you know, they may sometimes use those compounded, privately created products at certain cost and all the rest of it. None of that stuff falls within British Menopause Society guidelines. None of that stuff is recommended by people who are scientists working within menopause. So there's a small chance that if you go back to your GP, say like you have a medical card and you need the GP to rewrite a private prescription on the GMS paper, or like the way GPs can phone in or email in prescriptions to pharmacies nowadays.
Yes.
They're not going to do it for you. You'll have spent 200 or 300 euros on a prescription for stuff that no prescribing Irish doctor is going to back you up on. So I think it'd be really important before you spend big money to make sure that there is a relationship between either that UK or Irish clinic and a pharmacy and what the costs might be so that you don't get disappointment.
Right. Okay, fantastic. Is there anything else, Deirdre, you would like to say before we wrap up just on this, this whole area?
I'm a bit scared about the 23rd. I don't know what the hell. You see, I tend to talk a lot, so I don't know what the heck I'm going to be able to confine myself to in the few minutes. I'm going to spend the whole day there, so I expect to be able to chat to people wandering around and at the coffee breaks and all the rest of it.
Yes.
And that really just to say that, you know, I'm a big old communist. I'm sad that our event is expensive. But we're going to look at that for next year. You promised me that. And that maybe we would find. Find ways for people without, you know.
Yeah, we will. I mean, the thing is just to cover that off, Deirdre, and just so anybody who's here who isn't going to the event, and the sad fact of life is putting an event together at this level costs a lot of money. And it costs a lot of money in this country. So unfortunately, we have just had to create a situation where the event is paying for itself. But I made this point when I was when I was interviewed on the Irish Times Women's podcast by Kathy Sheridan, and Kiva was with me on that, and so was Sally Ann. We did approach the government for funding for this event. Nobody has written me a check. Nobody got back to me. And also the cost. Now, it's sold out at this point, so this is all academic, okay? But just for the record, the cost that was charged this year, which is €169, includes a 23% VAT cost that goes to the government. So the cost is actually €137. I contacted the revenue commissioners, and I was told, on, you know, in no uncertain terms, that 23% VAT would be, I had no choice but to do that. So as I say, all of that is academic for this year, because even if I wanted to, I couldn't squash more people into the round room. We've got 520 people there on the day.
Do you know what might be, you know, a good result of this event, and it's, I hope, success, is that maybe the powers that be will have a look at this and say, wow, there really is an unmet need here, and maybe hire you and Shell to organize.
Well, that would be great.
For profit.
Yeah. Well, the great thing is, Deirdre, you know, that, and just to let everybody who's on here today know, most of the government departments are actually attending the event. So next year, no one can say the who, the what, missed that, because quite a few of the government departments, and more than I actually expected, and you know, in fairness to them, are actually going to be in attendance at the event. So we'll see what happens. We'll be announcing the dates for 2024 on the 23rd of March. So we're all systems go on that, but we'll see what we can do next year, because from myself and Shell, who's my business partner, perspective, we're very proud, Deirdre, to be part of this train that is moving information forward around this whole space. It's a space that's very close to my own heart. 54 and hit menopause at the beginning of COVID, and had the most hideous brain fog. I had no idea that brain fog could be at that level, where I genuinely thought I was developing dementia, and I genuinely thought that. So that has been my motivation for putting this together. But you know, year one, we're doing what we're doing, and we've put together a really strong event, and we've amazing people, and yourself included, and then we'll see what we can do moving forward in the years. Because as I always say to people, Deirdre, this isn't a COVID situation. It's never potentially going to go away. 50% of the planet, if they're lucky enough to reach this age, will be going through menopause, and that's a no choice scenario.
Oh, absolutely.
So,
absolutely.
We need to get gemmed up on
this. This is like an inaugural event. I'd love for this to be the launching place for a more, you know, nationwide supported event for people who are interested. Absolutely.
Well, that's certainly our ambition, Deirdre. So so look, I'm just looking at the clock there. It's 19:33 now, so I think we might leave it at that. But listen, thank you so much for your time this evening. We really appreciate it. You know, it's invaluable content for people, and it's great to be able to get it out there to as many people as possible. Okay, enjoy your evening, and thank you everybody for joining us. And next Monday we'll be talking to Loretta Dicknam, founder and CEO of the Menopause Hub, and then on the 20th, which is the Monday of the week of the event, we'll be chatting with Sally Ann Brady of the Irish Menopause. So thank you everybody for your time this evening, and hopefully see you again this time next week. Thanks a million, Deirdre. Talk to you soon. Bye.